So thanks for asking me to come, Carrie. So my name's Cora Spina. I'm a nurse practitioner. We'll talk a little bit about our service, but I'm one of the nurse practitioners on our inpatient diabetes consult service. So we'll run until about noon, and hoping that this talk can be, pretty, doesn't have to be formal. So if you guys have questions as I go along, please don't hesitate to stop me. I put my contact information on here. Email is always great, and then second to that, I would say go through the paging operator. Some days I'm in clinic, and sometimes I'm in the hospital, and if I'm away, then they'll know that I'm not reachable. So part of the reason why I'm happy to talk to you guys is mainly just to kind of have a face to my name, and for you guys to feel really comfortable contacting us as a resource if you have questions related to inpatient management of diabetes. So I feel like I'm like an island girl at heart. I am from Seattle, grew up here, but kind of easygoing, so I'm hoping that this talk will also be. Don't make me sit up here and talk the whole time, is what I'm saying. So if you have questions, please ask me. So some of the points that I was hoping that we could talk about today are who we are, kind of what types of resources we offer. We'll talk a little bit about sort of what the recommendations are now in regards to inpatient management of diabetes for cardiology patients. We'll review a little bit of diabetes physiology, which I think is always helpful kind of when we're starting to put recommendations into place. We'll talk about navigating through CPOE, so that's the computer provider order entry, which can sometimes be a little bit cumbersome. I'll share with you some of the things that I do to optimize blood sugars for our hospitalized patients, and then happy to talk about other issues as well. So just kind of while we're looking at the objectives, any other points that you may want to cover over the next 15 minutes, or does this kind of look like a good comprehensive quick and dirty on diabetes? Yeah? Okay, cool. So who watches Scandal? Nobody watches Scandal. Oh my God. So
Third person who's told me to watch.
I know, yes. Well, because here's why. So I used to watch it like on Netflix, like back to back, like every episode after. And then like I feel like current season, not as good. So I haven't been watching it more recently, but season 1 and season 2 and 3 are pretty good. But anyway, so this is Olivia Pope, and she's basically like the fixer, right? And so I've been at the U for like 15 years at least. And my interest has been diabetes for a long time, but I've gone through many different roles within the hospital. And so for many years, I had been feeling like everyone's just asking just me about diabetes. And what we now have, as of 2 days ago, is a full complement of diabetologists that can be resources to you all in the hospital. And so don't feel like you just have to call me. Feel free consulting the rest of our team as well. So who we are we're an inpatient diabetes consult service, currently known as the hyperglycemic consult service. So if you're wanting us to help you, call through paging and ask for a new consult from the hyperglycemic consult service. That said, we may end up changing our name because even just that has been kind of confusing. We can help you with medical management of diabetes during the hospitalization. We should be looking out for patients that are at high risk. And so in general, those are patients on an insulin pump or people on U500 insulin. So for sure, if any of those patients you're admitting, make sure that you page us. As well, we have a transition clinic, and it's staffed by myself, another nurse practitioner named Mary Jancy, and our new director, Dr. Jing Chow. This is us. We're over at Roosevelt. A little bit important because a lot of patients that are used to coming to the hospital and seeing practitioners at the Regional Heart Center come to my appointment, and they get very frustrated when they say, hey, I checked in at 1 p.m. at the hospital and your clinic wasn't there. So we're actually just on Roosevelt, and we also see endocrine patients as well. But my panel is mainly just patients newly discharged from the hospital, and I'll typically follow these patients. Oftentimes they're post-transplant. So I'll kind of keep them for the 3 months after transplant, and then eventually graduate them back to Alaska or some other diabetologist or primary care provider that can follow them long term. But I have a hard time letting go of my patients. So I do have patients that I've kind of continued to follow for years. So why am I here? So Carrie asked me to come because we have a growing number of patients with diabetes at large, right? And so these patients come through our hospital, and whether it's their primary diagnosis, something that we identify during their hospitalization, they're all over the place, which is why we now have this service, to really manage these patients safely. So much of this you may know already, but when you're managing your patients in the hospital, typically they're one of 3 categories. They either have known history of diabetes, so maybe they are a really high functioning patient with type 1 diabetes that just has a little bit of heart failure, and you're managing them for a short time, right? Getting over that acute situation. Maybe they have had poor primary care for a long time, and we're identifying it as a new diagnosis during their hospitalization. Many times I see patients where this is really just temporary. So maybe they've had some complex cardiac surgery, maybe they're had a transplant years ago, we're hitting them with high doses of pulse dose steroids in the setting of rejection. We would consider this medication related or complicated by medications. Or maybe they're just, really sedentary during this acute state where they're just a little more insulin resistant. Have you guys heard the term malglycemia? Is that a term that's sort of coming up? Well, it's new. I didn't make it up. One of my colleagues from the Diabetes Care Center, Dr. Hirsch, sort of has been describing this picture of, well, the blood sugars aren't normal. And so we call this malglycemia. And that can be patients with low blood sugars, patients with high blood sugars, or what we're recognizing as being very important as well is this glucose variability. So hypoglycemia, by definition, it's blood sugar less than 60, right? And so we know that when that occurs, we can have bad outcomes. And oftentimes, that can be directly related to some heart wall motion abnormality, which can result in some cardiac arrhythmia and sometimes even death. So that's bad for your guys' patients, right? As well, if your blood sugar is too low, you can go into seizure, and then you can actually have long-term problems with brain activity. So we know that's bad, right? Hyperglycemia, it's been really well documented that that's a bad thing, but when we think of when it starts getting bad, really when your blood sugars are above 140, there is this activation of T cell dysfunction. And so mainly what that means is you start activating this inflammatory response. And so that can be harmful for people that are new post-cardiac surgery. As well, you go into this osmotic diuresis, right? So then you're volume depleted because your glucose molecule in your vessels is a large molecule. It's just going to pull all the fluid and you're going to urinate it out. So we worry about patients that are going home and continuously hyperglycemic because they're at risk for falls and things like that. We know that it can increase your length of stay during the hospitalization. Sternal wound infection has been well documented. And then as well, you're in a hypercoagulable state, so which puts you at risk for MI and stroke and things like that. But as well, even when your blood sugars are high, even for a short period of time, we know that it takes a while for the inflammatory mechanism to actually resolve. So sometimes I hear nurses say, oh, okay, well, the blood sugars were like above 200, but 3 hours later, we got it back to normal. Okay, well, that's great, but a lot of this up and down is also not good. So there's a lot of controversy about sort of what we do for our patients in the ICU around diabetes, right? So like back when I was like a staff nurse, well, actually no, I wasn't a staff nurse then, but like let's say more than 15 years ago, right? We didn't really pay too much attention to diabetes, high blood sugars. We used sliding scale, right? Giving people more insulin or some insulin if their blood sugars were high. We kind of knew that it wasn't a good thing, but we didn't really have good outcomes to really justify the need for optimizing blood sugars or normalizing blood sugars is what we used to do. And then in 2001, Dr. Greet Vandenberg came out with a pretty compelling study that basically looked at these patients in the ICU. It was a mixed ICU, but basically found these dramatic improvement in outcomes when blood sugars were actually really tightly normalized. And if you've ever talked to Dr. Peter Van Homeyer, he'll say, oh, well, I've been to her ICU unit and she manages these patients, like really tightly, and it's like a laboratory. So it's true. After her study was published, we had like great response in the community, right? ICUs all over the country were trying to normalize blood sugars as tightly as we could do it based on, the information that we got from her study. So at that time, there were recommendations to normalize blood sugars in the ICU to like less than 110. SCIP, are you guys familiar with this acronym? So Surgical Care Improvement Project is something that came out, more than 8 years ago, and they created something called SCIP-4, which was basically a metric for hospitals to subscribe to that basically looked at patients post-cardiac surgery, and the measure was to optimize their blood sugar to less than 200 post-op stays 1 and 2 after cardiac surgery. And then over time, they actually made that target a little bit more conservative when we started to see more risk, so more harm than benefit for these patients when we started to normalize their blood sugars too much. So are you all familiar with NICE sugar? So NICE sugar, I can't remember the acronym, but basically they looked at larger studies and looked more closely at patients that were put on intensive IV insulin protocols and actually found that, well, you know what, there's not like a ton of benefit that would outweigh the risk of harm being low blood sugar, to really justify tight blood sugars for these patients in the ICU. So then there was this huge reaction. So then everyone was like, sliding scale, blood sugars in the 200s, they're okay, right? So now in 2015, it's just kind of like, let's put it all together, right? So we know low is bad, we know high is bad. So can we live somewhere in the middle? And so our current recommendations from the American Diabetes Association and American College of Endocrinology are really that we should be initiating insulin, preferably IV insulin, in the ICUs when blood sugars are above 180. The target blood sugar right now in the ICU, once you start IV insulin, is probably safely managed between 140 and 180. We kind of did our own kind of improvement evaluation a few years ago when we were still subscribing to SCIP-4. And we, at one point, were managing, thankfully, from Carrie and the rest of her team, we were using a target blood glucose of 100 to 140 in post-cardiac surgery patients. And we were worried that we were getting too many low blood sugars doing that. And so for a period of time, we said, well, you know what? Given all the new information, what about increasing our target range to 100 to 180? And we didn't actually even really see like much change. We actually saw less hypoglycemia. So we have been actually sticking with 100 to 180 as our target range blood glucose for everyone, including patients post-cardiac surgery. So that said, very late, I did send you all over a research article, and that's the study that actually isn't even out to print yet. But Dr. Perez is kind of one of the leaders in inpatient management of diabetes. And just this month, basically published a study which actually looked at, very interestingly, right, we're all looking at the patients with a history of type 2 diabetes, actually found that for patients post-cardiac surgery, so they looked at people with CABGs and valve replacements, when they used a target blood glucose of 100 to 140, patients without a history of diabetes actually had better outcomes. So what do we do here? Oh, wait, actually. So same kind of thing. So basically, we still know that there are bad outcomes if your blood sugars are high. But what should we do? Looking at all the literature, basically it guides us to really know that high blood sugars are bad, low blood sugars are bad, and if we can safely optimize blood sugar, then we may want to try for that. So recommended is 140 to 180. If you feel really strongly and if you feel really confident that our units can optimize blood sugar to a tighter goal range of 110 to 140, that's probably better. But both low and both high are not good. I'm just gonna, oops, shoot. Anyways, so we here at the U, we basically do 100 to 180. At some point, we may change that, but we haven't really felt like, in terms of nursing management of the IV insulin drip, that we could really justify doing it safe enough to make our target goal blood sugars lower. Yes, Carrie Boone.
So I have a question.
Yes.
So
Keep
you
talking.
have been a huge proponent for
Yes.
100 to 180.
Yes.
Yeah.
Yes.
So it would seem that without SCIP now, as of
Yes.
2015.
Right, and then, so yeah, update, skip, went away.
Yeah, SCIP went away. There seems to be, not a huge push to control people quite as much.
Correct. Not as tightly. Yes.
Yeah, I would worry a little bit, just like not worrying about people as much being out of range. And so
Yes.
I just wondered if we should truly continue to keep people in range.
We say yes. So is your question, are you feeling like as a culture we've gotten a little bit more laissez-faire or comfortable with blood sugars that are sort of in the 180 range? Is that what you're trying to say?
Yeah, or higher than 180.
Yeah,
Like,
I
it's
agree.
not really-
Totally. And I must not have actually put in my most recent version. Darn. But hold on, let me look. Oh, anyways, so what I did have was a really pretty slide of a patient. So we've just actually completed a study on our bone marrow transplant units where we actually used a different IV insulin program. It's called Glucomander, and it's actually the one that in the study Dr. Umperas used. But basically, it was a software program that told the nurse exactly what to do. Your blood sugar is this, 2.1 units an hour or whatever, right? And so our patients, and these are patients that are getting high doses of IV methylprednisolone post bone marrow transplant on TPN, we were able to, on a non-ICU unit, actually control their blood sugars to a target blood glucose of 100 to 180 with very little low blood glucose. And our threshold for low blood glucose was like less than 70. And so kind of back to the Dr. Vandenberg, it's like, yeah, when you have nurses that have the availability and have the understanding and have the right protocol to optimize their blood sugar, and if it can be done safely, we would want to do that. At this institution, we're not there yet. But we hope to be now that we have this kind of full complement on our service. So, okay. So just really quickly, so the ADA also recommends for patients that are hospitalized that we have a documented hemoglobin A1C within 3 months. But I want to tell you that the A1C is not the best marker, right? So for your patients that have an LVAD in place, patients that have had some type of valvulopathy or prosthetic valve, that red blood cell is basically going through that mechanical device and it's getting swished around. That makes that hemoglobin A1C probably unreliable. And there's been no studies out there yet that say, hey, well, a person with an LVAD with an A1C of 11.3 actually is comparable to a normal person with an A1C of 7. We don't have that yet. But at this time, it's probably not worth drawing that lab sample on admit, which I see a lot as well. Now, if you're seeing someone in clinic that is going to have cardiac surgery, we tell those providers, hey, if all these other things are not true, then go ahead and draw one, because when we end up seeing them post-surgery, it would be useful information for us. As well, anyone with any type of anemia or iron deficiency, or actually even on iron supplements, would not be appropriate. Okay, so quick review, right? So you know that normal homeostasis is to normalize your blood sugars, probably in the range of like 70 to 90 all the time, right? So when you eat, your pancreas is gonna secrete the appropriate amount of insulin to drive your blood glucose down. When you're fasting and not eating during the night, your pancreas is gonna secrete glucagon to make your liver produce glucose. So that's normal mechanism. So for people that are coming into the unit with a history of type 1 diabetes, remember type 1 means that you have an autoimmune disorder. So you are killing off those little beta cells that normally produce insulin. So you're unable to produce insulin. So you're dependent on exogenous insulin. Usually you're thin, your insulin doses are pretty low. That's very different than someone with type 2 diabetes who has a large problem with too much insulin production actually, and they're actually insulin resistant. Their body habitus is usually larger, they're usually sedentary, and their risk of DKA is actually lower. Typically, I only see that when they're newly diagnosed with type 2 diabetes. So more than, let's see, this is published in 1995. So 20 years ago, there's a pretty impactful study that actually looked at, so the UKPDS looked at patients that were diagnosed with type 2 diabetes, and they found that at the time of diagnosis, which is 0 here, they had lost about 50% of their beta cell functioning. So it's not surprising that when we see patients with a new diagnosis of diabetes, they may already require insulin to normalize their blood sugars. So that kind of really drove us as a community to reset our screening parameters and reset our target ranges to kind of catch these people in the pre-diabetes stage. So when people get diagnosed with type 2 diabetes, one of the first things that they lose is their first phase of insulin secretion post-meal. So on the top graph are patients that don't have diabetes. You hit them with IV glucose and you see an appropriate response. They have this first phase of insulin secretion and the second phase of insulin secretion, which then results in a normal postprandial blood sugar, despite what they ate, right? And then the bottom, they lose that first phase. So we see this very commonly. So we talked about type 1, we talked about type 2, but what about these people that come in post-transplant? So there's 2 sort of major classes of medications that we use post-transplant. And so the first one is calcineurin inhibitors, and so those are like the cyclosporins, the tacrolimus, and the way they affect blood glucose is they actually destruct the beta cells. We don't know, sometimes it's temporary, and sometimes that can actually be permanent. As well, for patients newly post-transplant, we're gonna hit them with tons of steroids and then we're gonna taper it down, right? That's actually a more direct and a more kind of quicker result on their blood glucose. For both of these patients, though, what we'll see that their fasting blood sugars are actually not that bad, but their post-meal blood glucose is where the problem is. So in the hospital, we don't really, especially in the ICU, right? We don't really have a ton of tools. It's basically just insulin. So for us, it's really important for us to really kind of understand the action profiles of the insulin, kind of what the goals are for these patients, and using them appropriately to basically meet our objective, which is optimize their blood glucose safely. So I may say these terms back and forth, but when I think basal, I'm thinking, look at your fasting blood glucose. So basal is the insulin that you would need to basically tell your liver to quit making glucose in a fasting state. So to figure out what the basal needs are, I would oftentimes look at their fasting blood glucose first thing in the morning, or your basic metabolic panel. When I'm thinking prandial or nutritional insulin, that is the amount of insulin that you need to drive the glucose into the muscle cell. And it's really this that's most impacted by your steroids and your other immunosuppressants. So for you guys mainly, everyone's on an IV insulin drip, right? Not everyone, but many times. So who do you think should be on an IV insulin drip? You guys get like a lot of like pushback from the nurses. Oh, my patient's eating. Should this person be on an IV insulin drip? Probably not long term, but if this is someone on cards B who's coming in already with a history of type 2 diabetes, poor primary care, not taking their insulin, with an accurate A1C that's like through the roof, and we hit them with pulse dose IV methylprednisone, and you ask me how much insulin I want, I have no idea. So temporarily, I may say, just hit him with an IV insulin drip. We need to kind of sort of optimize his blood sugars quickly, and then we'll kind of figure out based on the patterns. If the patient is eating, and eating consistently, not like your 80-year-old lady who is not NPO, but only taking like sips of clears, someone that's actually like eating full meals, we would want to then, on top of their IV insulin drip, write for a set dose of scheduled prandial or nutritional insulin before each meal. That's pretty complex for the nurses, it's pretty complex for you guys, and so hopefully those are patients that we're following. And I think we have to. So if you write that order in pharmacy, your ICU pharmacist will say, have you contacted us already? Oh, here it is, okay. So here's my patient on the bone marrow transplant unit, right? So when we can do it safely, it's pretty cool, but you know, maybe we'll get there at some point all over. So just something to kind of think about when we have people on IV insulin, right? So when we think about the pharmacokinetics, so that's like, okay, what's happening in the bloodstream with your insulin? That can sometimes be different than the pharmacodynamics. So what's actually happening with this patient who has poor renal function, blah, 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 right? So this graph on the left is basically looking at Lispro and regular insulin, both given IV. So one thing to kind of look at is, okay, basically the action profile is exactly the same. So it's not worth using more expensive insulins when you're giving insulin intravenously. So all of our IV insulin is made with regular insulin. But if you notice, it's got a pretty-ish, you know, like quick onset. So it should be working like within like 10 minutes. And then if you cut it off, it should go away pretty quickly. The half-life of IV insulin is like 6 minutes. So theoretically, if you give it and you have a low blood sugar or whatever, and the nurses turn off the IV insulin drip, which is what they should do, you should recover pretty quickly. That said, you know, if you have someone with really bad kidney disease or someone that's like on dialysis, that 6 minutes may actually be quite longer, and so then we would worry about lows. As well, when we're planning for people at discharge, you know, that might kind of make us be more conservative, knowing that people have great renal function when they discharge, and then oftentimes are more challenged when they leave. So this is our UWMC IV insulin drip. Currently, I guess we'll look at the orders, but basically, so when the nurses are getting these orders, they have to print out a paper document, and it basically has 4 algorithms. The algorithms on the left are more conservative, so the titration, you know, instructions are very slow. That would be someone that would be appropriate for type 1 diabetes. And then as you move to the right, as the algorithms get larger, then hour to hour, those dose increases are going to be more aggressive. So when you're writing orders in CPOE, I want you to add and search for RX IV insulin. And there's really 3 things that you guys have to do as prescribers. You have to identify the target range. If you forget, the default is 100 to 180, but only for the ICU, you could choose 1 to 140. There's going to be a hypoglycemia protocol that the nurses are going to follow. And then you have to identify what your dextrose solution should be. So that said, right, I know in the OR, our cardiac surgery anesthesia colleagues, when they're looking and they are following blood sugars really closely in the OR, and they have felt, and it's true, they have felt that when they introduce dextrose solutions, then they really battle the blood glucoses in the OR and then post-OR, which is actually true. The reason why our current power plan has this is because when we created the IV insulin protocols, we looked at people that were in the OR for hours and in an NPO status for a long time. If you give them insulin without glucose, and this is more especially true for people with type 1 diabetes, their free fatty acids go up, and that really increases the risk of low blood sugar. That said, we've actually haven't seen a ton of bad outcomes for these cardiac surgery patients in the OR and in the ICU with IV insulin going without any dextrose solution. You guys are already battling all kinds of volume issues, so you don't have to. But in general, we should be thinking a little bit about it if they're prolonged NPO and especially if they have type 1 diabetes. And then the other thing that you have to identify is at the bottom here, you need to choose which algorithm you're going to start them in. So very commonly, we would start people in algorithm number 2, and that would oftentimes be someone that already has a history of type 2 diabetes. Maybe we use steroids in the OR or post-transplant and post-cardiac surgery. So you have to choose either algo 1 or algorithm 2 as the start place. You can also initiate what's called a sub-phase for the high-dose IV insulin. And so this is someone where, gosh, the nurse has been following the protocol in algorithm number 4 for hours, 3 hours, and they call you and say, blood glucose is still above 180 despite being in algo 4 for 3 hours. Consider the high-dose algorithm, and what that allows for is just more aggressive titration. Our gestational diabetes patients in OB, they have like 11, 12, 13, 14, 15 because they're super insulin resistant and their target ranges are lower because they actually do have the literature that shows that their outcomes can be really bad if their blood sugars are too high. Okay, so now we're going to skip to subcutaneous insulin. So when we talk about insulin analogs, these are basically the insulin molecule modified in some way to basically play around with the action profile once injected. So basals are on that side, and then prandials are on this side. I want to just call this out a little bit because just this month, the price of Glargine or Lantus went up like through the roof. So for a vial of Glargine at our pharmacy, and we have like the cheapest like per like patient pay price, it's more than $300. It's like $320, yeah. And so a lot of plans as well are changing their formulary to some of the more newer analog basal insulin, so Levemir or Detamir, you may see patients come in on. It's a little bit tough because the action profile is not exactly the same. And so if they're coming in already on Detamir or Levemir at this time, just keep them on it. It might not be the right insulin for them, but because we don't know really sort of how that would equate to Lantus, keep them on it. And then in terms of the mealtime insulin, all the rapid acting, not all, but Lispro, which is our formulary, and Aspart, those two are pretty comparable. So if they come in on Aspart Novolog, feel pretty comfortable just using our formulary, which is Lispro Humalog. All right, so so basically this is regular insulin, which is in red compared to a rapid acting analog. Aspart is what we're using here. And basically, Aspart is faster than regular insulin, but it's not that fast. And so where we used to think it worked right away, it probably has an onset of like 15 to 30 minutes. So in the community, you may hear patients say, well, my doctor told me to give my Aspart 30 minutes before the meal, but the nurses don't give it to me until my food gets here. Well, yeah, we teach them to do that because no one knows like when their food's gonna get here or when like X-ray is gonna take them off the unit. So in general, we know that, and that's why our dose recommendations sometimes are conservative. So your ideal subcutaneous insulin regimen will be basically including some type of basal insulin, remember to optimize their fasting blood glucose, and then as well include some type of mealtime insulin if they're eating, and then in addition to that, correction insulin or supplemental insulin. So that's kind of what it looks like. This is probably a lot of review for you. But in CPOE, to kind of remind you to think about those 3 aspects, we have a power plan that's called RX Insulin Subcutaneous. Don't use the one that says Lispro/Glargine. Use the one that's more general than that. The one that just says, the one that's pending over to the left. RX Insulin Subcutaneous for oral diet. Because when the patient leaves the ICU and goes to 5 Northeast or whatever and eventually discharges, we can do this little light bulb that you see in the red circle there to send up insulin pens and other things that would be more appropriate for discharge. And then sort of at the bottom here is where you'll see where it says IV to subcutaneous insulin transition. That's an order that you would use when you're converting someone from IV to subcutaneous insulin. So I'll show you how to do that. So another useful tool for you, so when you're going in CPOE and you're looking under menu and you're trying to figure out who do I call for hyperglycemia, so that's me. I'm Cora Espina, but my full name is Corazon Espina Erickson. So that's me there as the primary provider for our team. But as well, you'll see this glucose insulin flow sheet. It's over to the right here. And so that will basically populate your blood glucoses, all the insulin that patient's getting administered. And as well, there's a little icon to the left that says IV to sub-Q. And that's a little app that can help you titrate someone from IV to sub-Q insulin. The app looks like this when you open it, and it basically auto-uploads information based on your most recent 6 blood glucoses, and then puts in, a weight. This is not super, it's probably too conservative for patients on your unit and doesn't accurately sort of consider all the other things that are going on, like vasopressors coming off and all that other stuff. So, but it's a good sort of shot in the dark if you need to quickly transition to someone and there's no one to help you. But this is how I think about it instead. I'm trying to figure out, I'm looking at the IV insulin drip and I'm like, so how much insulin is this patient using when they're not eating anything? And then I'm gonna take a portion of that number and I'm gonna think of that as their basal insulin. And then depending on how comfortable I feel, I would basically use that amount of insulin and deliver it to them as either NPH insulin, which is basically half of Lantus or Glargine, and give that to them as their dose. If I'm going to transition someone in the morning, so let's say you guys are rounding and you guys are like, let's get this person off IV insulin, and I'm like, I totally agree. But Lantus is not normally scheduled, at least in this hospital, to be given. So it's preferable that we give it at bedtime. But I don't want to make the patient be on an insulin drip for that long. So if I'm going to figure out that his Glargine dose is like 20 units tonight, I'm going to bridge it with NPH. And I might say like a one-time dose of NPH, and then starting tonight, 20 units of long-acting basal insulin. And that would be his every nighttime basal dose, right? So you use that little one-time bridge thing in the power plant, and that cues the nurse then to shut the insulin off after 2 hours. What we see oftentimes is the nurse sees the discontinue IV insulin drip, and then like all that work that they did overnight to optimize the blood sugar, once they turn off the IV insulin drip, if they don't give them any basal insulin, then they're hyperglycemic again. So if we're thinking about some nutritional insulin, and they're eating a little bit, it's better to just give them a little bit of insulin, so like maybe a couple units of Lispro before each meal, and then correction insulin on top of that, or supplemental. So this is the pretty flow sheet that I talked to you about when you get that from the chart summary. And this is a patient that I still follow in clinic. He's like a mid-40-year-old guy that has a history of hypertrophic cardiomyopathy, followed by Dr. Owens. And he actually had surgery from Dr. Verrier, so he did a maze procedure. A new history of type 2 diabetes, like 3 months prior to, and I think was on metformin, but didn't really check blood sugars before. Came in for surgery, didn't actually even get steroids, and was really insulin resistant, required a ton of insulin. And so kind of looking at his insulin needs over the days prior, helped me identify how much basal insulin I was comfortable transitioning onto. And so this is a guy where I used Glargine, but I did it as a BID dose because I anticipated that I was going to be tweaking the doses anyways. Okay, so any questions so far? So the rest of this is just kind of like for patients that are maybe with you guys in the ICU for longer and trying to still optimize their blood glucose. So let's say the patient is on tube feeding, right? So if they're just starting continuous tube feeding, just keep them on an IV insulin drip, right? But at some point, if they transition to like nocturnal tube feeding or bolus tube feeding, it's probably worth us figuring out how much subcutaneous insulin. Or if the blood glucoses have been pretty stable and the IV insulin requirements have been pretty stable while on the IV insulin drip and on continuous tube feeding, we should just transition them at that point as well. So again, I like to separate out what I think their basal needs are. So if this is someone that had type 2 diabetes and was already on like 20 units of glargine and then came in and required tube feeding, I know when we eventually remove the tube feeding, he's gonna need glargine anyways, so I might just start him on at least 20 units of glargine. Or I might take the total daily dose on the IV insulin drip and use both his basal and tube feeding related insulin needs, but use it as NPH. Well, what if I'm like, oh my God, that ends up being like 80 units of total daily insulin a day. I just kind of feel weird about giving so much insulin when I'm really guessing about the doses. So what we've done actually pretty successfully, this is a model that Harborview uses, is actually use NPH. So NPH, remember, has sort of like the duration of 12 to 18 hours, and it has sort of a small peak. But when you give it 4 times a day, things kind of like flatten out, and where one of it's peaking, then the other dose is kind of like going away. And so it actually allows for a steady stream of background insulin, but allows a 4-time daily dose so that we can continue to tweak the doses. So we do that a lot. And then this is where we ask our dietitian colleagues, well, we want to get the caloric need met, but if you can do that with a less carb dense formula, then let's try for that, because we know that their blood glucoses are going to be high just from the tube feeding. You guys don't usually see patients on bolus tube feeding, but this is where I might use bolus. This is where I might use regular insulin. So sometimes we'll use regular insulin 3 times a day if the patient is getting sort of a longer, bolus of tube feeding. So once we basically transition them onto whether it's NPH or whatever, right? Just kind of let us know as your plan changes, right? Because sometimes we'll have a plan like in the beginning of the day, and then during evening sign out, they go, oh, you know what? And tonight we're gonna just drop them down to like nocturnal tube feeding. So if we don't know that and we're giving you recommendations, we may have them on too much insulin where they're gonna get NPH during the day when they actually only need it maybe at bedtime to cover that 12-hour nocturnal tube feeding. So let us know, we're friendly. We're looking at this all the time. We are calling the nurses all the time to say, hey, there's no blood sugars in there. How much insulin is he getting? You guys, Carrie, you probably don't see a ton of people on TPN. Oh, okay, cool. So easier, just put them on IV insulin. Again, we'll figure it out, and these are patients that we can help you with. Similar to the tube feeding, I'm using the IV insulin drip to kind of figure out what their needs are, and then I'll put a proportion of that in their TPN. People think that that's unsafe to have insulin in the TPN bag. It's actually the best way to do it, because if they discontinue the TPN, that regular insulin is also discontinued. So we actually see less number of hypoglycemia when we do that. So briefly, we'll talk about admission orders. Totally underdose. It's okay, right? Because we don't know if they're really taking the insulin, that you're getting the history from like, I don't know, a relative that doesn't even live with the patient, right? But give them some insulin. We have a hard time correcting when like someone says, I take 100 units of glargine, and then I come the next morning and it's correction insulin only. So if there's some history, put them on some amount of insulin. As well, if they're eating some meals, but just not eating 100%, you can hit them with a little bit of nutritional Lispro. In general, all of the injectable and oral diabetes agents should be discontinued when you admit them. So some of the most frequent ones that you'll see are metformin, right? We don't like metformin in the inpatient setting because if they need IV contrast, we would discontinue it anyways. But we love it as an outpatient. And we love it for these type 2 diabetics because it really makes them insulin sensitive, whether it's their own endogenous production or our injectable insulin that we're giving them. You guys don't see this a lot because you guys have a ton of heart failure patients, but your Actos, your Avandia, those are the pioglitazones. Those often increase the risk of heart failure, so we want to cut those. So any of the secretagogues, those are like the sulfonylureas, so the glipizides, uride, imipiride, like that sound is gonna make the pancreas secrete insulin. So discontinue them when they're admitted because we're gonna just prefer to use scheduled mealtime Lispro because that's gonna be easier for us to add and discontinue if their food intake changes. Has anyone heard of Afrezza yet? Okay, so Afrezza, you may see this on your, looking at your med history. So Afrezza is the new inhaled insulin. So it came out like, let's say 4 months ago, and it's basically a rapid acting insulin analog. So each little puff is worth like 4 units of rapid acting insulin. So if you see it and you're like, I don't know what it is, I'll just continue it, it's insulin. Are you all familiar with the incretins? This is another class. So these are the Bietas, Victoza, those are 2 brand names. Liraglutide and exenatide are the generic names. And mainly, these work on these gut hormones, specifically in the intestine. And what it does is, so you normally have GLP-1 that you secrete. So when you eat a meal, you secrete that, and it does a couple things. It kind of slows your gut to absorb all that glucose appropriately. It tells your brain to be full, satiety, right? So that you stop eating. And that appropriately releases insulin for the meal, and it turns off your glucagon so that you, again, normalize your blood sugar. So for people with type 2 diabetes, they have less amounts of GLP-1. So we give them basically a GLP-1 agonist, which are those 2. It's an injectable medicine, so people say like, I don't take insulin. They sometimes think it's their insulin. But basically, we wouldn't use it in the inpatient setting because a lot of times they're on opioids. They're already that's gonna slow their gut. This is gonna be too much for that. They're expensive, and we're gonna use insulin anyway, so it's kind of a waste of money. And then if you look here, the DPP-4, so DPP-4 is basically a peptide that in your body gets secreted to turn off your GLP-1. So DPP-4, what do you call it? Basically, so the pill form of DPP-4 is sitagliptin and linagliptin, and it allows your endogenous GLP-1 to be more available. So DPP-4 cuts down the GLP-1, and then the injectables are giving you more. Does that make sense? Okay. So this is sort of a newer class, so SGLT2 inhibitors. So they sound like ganagliflozin, Invokana is the sort of like most advertised one. And this is, again, for type 2 diabetics, but it actually puts you in a state of osmotic diuresis for a little bit of time. And so you basically urinate all your glucose. So very cool thing, my guy with the Maze procedure 2 years ago, he's like off insulin, just on metformin, and then Invokana, and had been doing really, really, really well. But he's getting all kinds of like ablations and stuff, and so we ended up doing something else for him. But anyways, a very good medicine, but what's important for you guys is just last month, I think, there's sort of like a new black box emergency warning because there have been cases, actually some at the U, where patients were on a GLT2 inhibitor and then went to surgery and had prolonged periods of NPO status and actually went into ketosis. So if you see this medicine, discontinue it, especially because they're likely going to go in the OR and be fasting for a long time. There's the Afrezza. There's also now Toujeo, which is basically Glargine or Lantus, but it's U300. So basically, it has the same chemical as Lantus, but it's actually more concentrated. So we still give it once a day, but we can get by with smaller doses to have the same duration and effect. Because the thing with Glargine is like, so let's say you have patients that are giving like 100 units twice a day. It's probably not working because it's a large sort of acidic molecule that's actually changing the profile underneath that subcutaneous space, and it's probably a waste of money. So we have a lot of patients now on U300 or Toujeo. So you should be calling us if you see patients on insulin pumps, but basically these pumps basically deliver a set amount of insulin based on formulas that we're putting into the pump. But patients have to be alert, oriented, blood glucose reasonable, food intake pretty stable, so not patients that are in your ICU. But if they've been hanging around for a while and we're just waiting for a bed on 5 Northeast and may even leave in a couple days, we would maybe transition them at that time. This is what they look like, because sometimes they go through the OR and no one realizes they actually have insulin going through. So let us know. What's that? Yeah, it happens like more times than we are embarrassed to admit. So anyways. And then other resources, the nurses should be doing all of the bedside teaching. So sometimes I get asked, hey, will you teach a patient how to use a blood glucose meter? The nurses know that. Even in the ICU, they can get help with that. So they teach how to use a blood sugar machine, a glucose meter, how to self-inject insulin. Any questions in my last 1.5 minutes? Yes.
With the little insulin pump,
Yeah.
Todd was wondering if.
Yes.
So is it monitoring on the
I
patient's
know.
right?
Not yet. So eventually, right? So they have this thing called artificial pancreas. We don't really have a closed loop system. We do not have a closed loop system that monitors it and then feeds the right amount of insulin. However, what we do have, and you'll see where it says mini link transmitter, that is a continuous glucose sensor, which is this graph here. And it's basically showing a graphical picture. It takes basically a snapshot of capillary blood glucose every so many, 6 minutes. And basically, we want to use it more for trends so that we can catch a low before it happens. And that's a separate thing to the actual pump, which is on this patient's left side. That's actually delivering insulin. They have, yeah, so they have another little device thing. Sometimes now they actually can link to your smartphone, but there's another separate pager-like type thing that basically graphs it for them. They still have to check their blood sugar 4 times a day. It's mainly just to kind of look at trends. And we actually have a study that I'm working with anesthesia on in the OR to basically try and look at surgical patients on continuous glucose sensors, because right now the FDA, we haven't done safety profiles to make sure that it's safe to manage patients on continuous glucose sensors. They can wear them, but we're not actually really going to be using that information to determine what their insulin doses should be, because that hasn't been studied yet. But we can say, keep it on, and when it alarms, it'll tell us when your blood glucose is going down to prevent a low from happening.
Are there studies doing that? Some people don't have that. I mean, it's such a barrier.
I know.
Home monitoring and self-monitoring.
Yeah, there's no real, we still need blood, and we still, it's just a formula. So it's not actually, it's measuring, it's actually not even measuring glucose, right? It's capillary blood, but it's the catheter sitting in there and all the blood is going through it, but it's not actually looking at a glucose and telling us. So it's not a for sure thing. All right. Well, thanks for having me.